Hi, Dr. Garima here again, and we are recording another one of the ADC, that's Australian Dental Council exam, return part one, mock SBQ, which is basically nothing but one of the questions asked in the previous exam. For all the new candidates, I'm just solving, or rather showing how to solve a question which is how it's asked in the exam, so you have an idea of what kind of questions are asked. Though the details of how many questions, percentage wise, from each subject is going to ask is mentioned in the booklet of the ADC. This is how they are going to ask questions. Once again, not everything is a straightforward MCQ based question. They are scenario based questions, which means that any scenario can have a different answer having the same options. So you have to read the question very carefully, identify the keywords because sometimes the questions can be big and the timeline is very short. So there is a lot of pressure, there's a lot of mental stress. But that's how it is. But it's doable. I did it in my first attempt. You can also do it. Just follow the right way to it. In the morning today itself, in my enrolled candidates group, I decided, I was thinking about it, but then today I just like, let's do it kind of a thing. So, of the 150 plus candidates that I have on my WhatsApp group for the enrolled ones, I just told them that now 2 months are left for the exam and start exercising a bit, a 30-minute of exercise after, studying or attending a clinic and then studying is very, very necessary. And I always did that before any of my very strong competitive exams because when you do a physical exercise in a gym or you're walking or running or swimming, whatever you like, first of all, you're happy because endorphins are released, your body's working out, and there is a sense that you can do it. You're full of that vigor and more oxygen is pumped in your body and brain needs oxygen to function, so somehow you focus better and just listen to music and 30 minutes just to yourself, but keep yourself active in those 30 minutes. That helps a lot, so do it and just to motivate you all, and showing that I'm also a part of it. It's not just that I'm preaching. I myself, I'm gonna do it 30 minutes a day. I was anyways walking and I do incorporate some form of activity in my daily life, but I'm like this time, let me set a goal, let me jog for 30 minutes on the treadmill because it's really hot out here in Dubai at the moment. It's like 50 plus degrees. I can't just go outside and it's extremely humid. So I'm like, let me do that on the treadmill. And so today I finished my 30 minutes. So see, I'm doing my part, you do your part. So let's go ahead, solve a question, and hopefully this helps you. And leave in the comments once you watch this video, and let me know if you want me to shoot on some specific subject. Though I'm trying to do it on a daily basis, one video a day to help you all. It's always nice to hear from you all. So let's start. You are seeing a 45-year-old patient with schizophrenia. It's a psychological disorder which happens. It's in nobody's hands. You start to basically hallucinate or act differently, may harm yourself, may not harm yourself, may harm others. But basically, whenever you have the schizophrenic attacks, you just don't tend to listen to logic and reasoning if you are under that spell. So the people surrounding you really have to be more supportive because the person who's having that attack is actually not intentionally doing something. It's a disorder. A sad one though, but yeah, people do suffer. So you have to be more compassionate and genuine and understand what not to say and do not aggravate a person when he's having those spells. So, anyways, this person, 45-year-old, is having that condition and epilepsy and needle phobia, and he was accompanied by his social worker carer, basically not family. Patient seems agitated, so he's already agitated. He has intellectual instability. Fair enough. It is difficult to obtain any information from the patient regarding his history and medication because he's agitated, he's not willing to cooperate basically. So you ask for help from a carer during the appointment to get the patient's medication list because some medications do interfere with our dental treatment. So it's always better to have the medication list to prevent any complications from happening. The clinical examination revealed gingival overgrowth on the label aspect from distal 3, that's the bottom left, extending to the distal of the fourth 3 region with a periodontal probing depth of around 6 mm, like big periodontal pockets basically. And there is overgrowth. Uh, OBG revealed deep carious lesion in 1-1 and 1-2 and root stumps in 1-8. His medical history revealed a history of epilepsy since 14 days of his birth. That means for 45 years he's having epilepsy with frequent epileptic episodes. His medications include Eptoin 100 milligrams, sodium valproate 500 milligram, levetiracetam 500 milligram thrice daily, like heavy doses. He has schizophrenia, which is being treated as well with the medication. Okay, so big history. But usually I find the cases with big history are pretty much straightforward. You know, the more the detail, the easier it becomes to treat. So whenever you see a big scenario, don't be afraid or scared. Actually, be happy. It's the small scenarios which give you a lot of problems. So out of this, I'm gonna pick up that he's having a long-standing epilepsy. He's taking 3 medications for it, and still he's ending up with epileptic attacks. So we all know that sodium valproate is linked with gingival hypertrophy, which is also mentioned in the question. So great for us. And he's anyways agitated and he has needle phobia. So straightforward, any form of surgical treatment that I'm going to do has to be under general anesthesia. I won't be doing on the chair because in spite of 3 medication, if he still has epileptic attack, then he's very much at risk of having an attack on my dental chair, and my dental chair is not a hospital. I won't be able to manage it, so he has to be treated in a hospital setting. And he's needle phobic. See, the difference between fear and phobia is an extreme level of fear that you just cannot reason out with the person if he has that phobic attack or pang of anxiety. You just cannot control the patient, and especially when a patient is also having some intellectual instability. Forget the reasoning is out of the window. The only way to deal with such patients is either to physically restrain them or take them under general anesthesia. A 45-year-old, a physical restraint is not advisable, especially when you have so much of work to do as well. You have caries, you have an extraction, you have gingival overgrowth, you have periodontal. For whatever reason you have to treat, it has to be under general anesthesia. So that part is very, very clear. So having had this information and I'm already knowing that whatever treatment I will be doing under general anesthesia, now I will start seeing what is the sub question. Pretty straightforward. Like big scenarios actually make me happy because I know I'm going to have one shot answers. I won't be confused much about it. So let's go. You judge the patient is not capable of giving consent for the treatment. Okay, fair enough. Who would provide the consent? Somebody has to sign that consent form, right? The patient presents with his personal care worker. His daughter, who is the legal guardian, is unavailable. What is required to obtain informed consent for an elective invasive procedure? See, this last line is so important. If there was an emergency procedure and a life was at risk, then the social care worker consent was enough. But when the question is mentioning it's an elective invasive procedure, what does elective means? Elective means a properly planned treatment procedure which you fix on a specific day. It's not a procedure that you immediately jump on to do it right when the patient has come for the first appointment because it's not life threatening or urgent or emergent. So, whenever you have an elective procedure, a proper consent has to be obtained, and if the patient is not capable of giving it, then the legal guardian only can give it. Write this down. Okay. So, having have this information in our head, let's see what are the options. The patient's presence implies consent. Now, Verbal consent, perhaps you can, I mean, obtain for a clinical examination, but just the presence of the patient doesn't mean that you can just do what you like. Obtain written consent from the patient, but then we already decided that the patient is not capable of giving consent. So, what is the point of obtaining a written consent? What is consent? Consent is the patient also understanding what needs to be done. And if you think the patient is agitated, not listening to you, not able to understand fully the consequences of what to do, and because when you give consent to a procedure, you are also giving consent to cooperate. And if the patient is having phobia, he's not going to cooperate. So, what consent are you taking? You know, obtain written consent from the personal care worker. If it was, like I mentioned, an emergency, urgent, life-threatening procedure that you had to perform and the daughter is not reachable, then social worker consent is fine. But for an elective, invasive procedure, no. Obtain consent from the patient's daughter, yes, because she's the legal guardian and that is mentioned in the question. Okay. The patient is needle phobic and his carer asks for nitrous oxide, minimal sedation. What will you do? See, first thing, nitrous oxide is not a substitute for local anesthesia. Nitrous oxide, if you ever have given to someone, would basically just help you to relax and cooperate, and it will decrease the threshold of your pain. It won't make you unconscious, it won't sedate you. And local anesthesia has to be given for a procedure if required. You give nitrous oxide or not. Nitrous oxide is also given to people who are cooperative, a little anxious or fearful, but they have to put the mask on the nose by themselves. You cannot like hold on to the nose and forcefully put that mask. And because after giving the nitrous oxide, you do feel a little lightheaded, you should be able to understand that if a person is already having some intellectual instability and he chooses to not listen to you and just remove the mask in between the procedure, there is a high chance of diffusion hypoxia. You can't afford that to happen. So in people who are having a lot of phobia, nitrous sometimes doesn't work. And first of all, even if you're not having phobia, it's not a substitute for local anesthesia. Local anesthesia still has to be given with a needle. So, having a patient who's having intellectual instability, who has to be given a needle because his procedure requires it, nitrous oxide is not the right mode of treatment. So, inhalation nitrous oxide is best indicated under this circumstances. Absolutely false statement is the wrong answer. You can use nitrous but inform the patient that you still need the needle for the LA. That is a good option and it's a true statement, but it doesn't fit here because I cannot use nitrous in this patient. So there is no point telling him that I can give nitrous, but the needle has to be taken. It's not fitting my circumstances because I cannot give him nitrous because of his intellectual instability. Prefer to perform the treatment under GA. Yes, because he's also having epileptic attacks. Suggest IV sedation. GA and IV you can contemplate. IV sedation is not a wrong option either. But then you can't do it. It has to be done in a hospital setting. And one of the best antidotes for epilepsy is GA. You know that. So I would prefer GA over IV. You have to extract 1, 1 and 2, 7. All the rest of his dentition are present. What would be the best treatment to banish the edentulous space in epileptic patient? Okay. This last 3, 4 words are very important. Best treatment, best, not just the treatment. Whenever a keyword like this comes, which is the best option, it means all the given options are correct, but you have to choose the best one. You understand? So this is not an MCQ question. This is a very analytical question. In this scenario, which would be the best one? You understand? So all the options, expect them to be correct, expect you to get confused. So watch out for the keyword best in what scenario? Best in an epileptic patient. Now, what is epilepsy? Epilepsy will result, assuming it's a general tonic-clonic seizure, it is like fierce contractions of the muscles of the body. When the oral musculature contracts, there are two risks. One is if any prosthesis is there in the mouth, it can fracture or it can displace, resulting in a choking hazard. Now, you don't want to give any of these two. Porcelain crowns can fracture. Porcelain bridges, ceramic bridges can fracture. Removable partial dentures can get displaced. So these are very risky things. What would be the ideal thing is giving either metal crowns, which is silver or gold metal crowns, or bridge of that, or implant. Only these two. So the question is specifically asking the best treatment in an epileptic patient. So I'm going to choose one of these options if it comes through. Implant, correct. Acrylic RPD, no, because it can get displaced. Chromium cobalt RPD, again, it's an RPD. It can get displaced. No replacement, no. The question is asking the best method. So implant out here is a good method. Now in this options, if they would have given a ceramic bridge, I wouldn't have chosen. Porcelain bridge, I wouldn't have chosen. But if they would have given a gold fixed partial denture, I could have chosen, and that can be a right answer. So any of these options that I've discussed can come in your exam. Coming to the daughter called afterwards and advised that due to financial issues they cannot go with the restoration plan, what would you do? Well, explain to the daughter that the health impact of not continuing with the plan treatment. Basically, explain to the daughter the consequences of not continuing with the plan treatment plan. You can do that, I guess. Report abuse. It's not an abuse. Not having money and so I'm not going with the treatment is not an abuse. Suggest a payment plan, not a wrong answer either. Refer the patient to the community dental clinic. All right. So in Australia, there are community dental clinics which work at a subsidized rates, and there the treatment can be done. So if the treatment has to be done, but it is just cannot be done because of the financial issues, and you think the financial issues are there, so even a payment plan is not going to work, then I rather refer him because they are willing to get the treatment done. It's just that they don't have the money. I might as well refer to a community dental clinic where the treatment would be done at a subsidized cost, which probably the patient can afford. So option C is not wrong, option A is not wrong, but option D is just a little better than option C and E, so I will go with that. What oral conditions would you expect to see in this patient? Recession, hyperplasia, low case weight. C. The patient is taking epileptic medicines, and we all know that epileptic medications can cause gingival hypertrophy. So I'm going to go straight with that answer, gingival hyperplasia. What you learned from this video: first, you are going to read more about epilepsy, the types of epilepsies. Second, about schizophrenia. Third, about the drugs which have been mentioned in the start in the scenario, those three drugs. Read about them, the side effects of them. Read about gingival overgrowth. Read about nitrous oxide sedation. Read about who can give the consent in which situations. So many things to learn from this question, and so many questions can be asked on the things learned from this question, and definitely a consent giving question will be asked in your exam. Definitely a question having some medical condition will be asked in your exam, and epilepsy is the favorite one, so expect. Plus in your own clinical scenarios, I'm sure you must be having patients with epilepsy. Like me being a pediatric dentist, I do deal with a lot of children having epileptic conditions. And I do ask a lot of questions as to when was the last episode. And since you have started the medicine, has the episode occurred? Because my treatment plan is completely based on that. There are times when patients have said the child is 5 year old and there were just two epileptic attacks till the age of 2, and since they have started the medication, there is no effect. Those patients I can treat on the dental chair, and I don't mind doing, because since 3 years, not a single attack has occurred. But I am in general prepared, and my assistant is prepared in case that happens. The first thing I would be, if at all that happens, I would be just stopping all the procedure and straight away giving oxygen and calling an ambulance. So I explain all these things to the parent. If the attack has not happened since like more than 2 years and the medication is going just fine. But if the patient gives me a history, that doctor, we have been taking medication since 5 years, but still on and off the attacks happen, though the frequency is less, and the last attack happened 3 months ago. In that scenario, I will not treat the patient on the chair because he's taking the medicine and still the attack has happened. I would straight away tell the patient that if I have to do any treatment, an invasive one, not just scaling or just examination, even if it's an extraction or a root canal, I will tell the patient that for everybody's safety, let's take it under general anesthesia. So you see, both the patients are epileptic, but depends on when the attacks happened, medications involved. I will choose to see which way of the treatment I'm going to perform. So read more about epilepsy. It will make you more confident to handle the scenarios because you will get patients who are having such conditions, right? So I hope you like this video, and I hope I continue to motivate you all and be a participant in your journey. And yeah, I'll look forward to my 30 minutes tomorrow of jogging. Leave me your stories, leave me your things that motivates you to study more. It will help other candidates. Your comments are read by others too on my YouTube channel. So have a nice day, and looking forward to tomorrow. Bye bye.